All right, so it's just transitioning over to Dorothy. Um, just want to thank everyone for coming to our part three of four um, Snap webinar series. Sorry, I know Dorothy gave a talk similar to this at the PNHP annual meeting that was very good, and so we wanted to invite her back to give a similar talk now, and one that could be recorded and saved for posterity for Snap chapters around the country to use and understand the intersection of fighting for racial justice and fighting for single payer. Um, Dorothy is a classmate of mine, and I know she's been dedicated to fighting healthcare disparities. And so just want to, without further ado, hand it over to her.
Thanks so much. So as Tony said, my name is Dorothy. I'm at the University of Pennsylvania. And I've been doing some work with White Coats for Black Lives and SNAP for some time now. And so talking about single payer and racial inequities is kind of my jam. And so I kind of wanted to talk a little bit about how single payer can become a solution to dealing with some of the racial health inequities. So I'm really just going to start with some background, I guess, about structural racism, talking about structural barriers to health and healthcare, talking a little bit about the history of segregated medicine and what it looks like today, and then also discussing single payer kind of as a solution to some of the racial health inequities. I think people are pretty familiar with discussing racial health disparity, right? So there's differences right now. That what everybody's talking about is Black maternal mortality rates being higher than other racial groups in the country right now. In medical school, we're taught about being Black being a risk for heart attacks and strokes and diabetes and high blood pressure and all of these sorts of things. And there are ways that we have to obviously push back against the narrative that it's not something inherent to Black people that makes us like more susceptible to these diseases, but it's also something about living in a racist society that makes us more susceptible to disease, that makes us more predisposed to having certain environmental exposures and stressors. And that comes from living in a society where we have things like redlining and people are more exposed to certain pathogens and issue like unclean water, like we see in Flint, for example. Here in Philadelphia, there's also issues with lead in the water. I know people in Baltimore are also organizing around that. And so these larger issues impact people's health. And so what we are trying to do is address some of those larger issues as healthcare professionals. And then on top of that, there's obviously the issue of accessing the healthcare system. And so those are kind of like the first two things that we're going to be talking about. So what is structural racism? So I kind of talked a little bit about this in my intro. So the Brown University Center for the Study of Race and Ethnicity in America defines it, and I think this is a pretty good and simple definition, is a normalized and legitimized range of policies, practices, and attitudes that routinely produce cumulative and chronic adverse outcomes for people of color, especially Black people. And so understanding racism as specifically an issue of anti-Blackness in this country in particular, but also globally, helps us kind of understand some of these sorts of policies and practices. So I mentioned redlining earlier. and how that impacts segregation, how that impacts what schools kids go to, how that sets them up for the school to prison pipeline, how there's disparate levels of policing in certain neighborhoods over others. Things about our built environment and how, Black neighborhoods are more likely to be built around highways, freeways, and be exposed to pollutants that way, or rather the reverse, that like we've designed highways to go through Black neighborhoods, for example, about things like food deserts. All of these things have huge implications for these chronic adverse outcomes, as this definition kind of says. So when we talk about systemic racism, right, we want to talk about larger issues. And so I think, there are smarter people than me who've said brilliant things about this. So we usually tend to see racism as like really overt acts of hate. So here in Black Power, the Politics of Liberation, Kwame Ture writes, when white terrorists bomb a Black church and kill 5 Black children, that it is an act of individual racism, widely deplored by most segments of the society. But when that same city, Birmingham, Alabama, 500 Black babies die each year because of the lack of power, food, shelter, and medical facilities, and thousands more are destroyed and maimed physically, emotionally, and intellectually because of conditions of poverty and discrimination in the Black community, that is a function of institutional racism. When a Black family moves into a home in a white neighborhood and is stoned, burned, or routed out, they are victims of an overt act of individual racism, which most people will condemn. But it is institutional racism that keeps Black people locked in dilapidated slum tenements, subject to the daily prey of exploitative slumlords, merchants, loan sharks, and discriminatory real estate agents. The society either pretends it does not know about this latter situation or is in fact incapable of doing anything meaningful about it. And of course, we would argue that our society pretends that these problems are not happening, and primarily happening to people of color and Black people in particular. So, that's kind of like a giant societal issue that we have to keep in mind when it comes to talking about racial health disparities. But we can also think about medicine as kind of a microcosm of some of these issues. And so we're just going to get into segregated healthcare in a minute, in the actual delivery of care, but I kind of want to think back to other issues kind of along this pipeline of segregation and health disparities. And unfortunately don't have slides with all this data in this set actually, but I just want to think more broadly kind of about the larger system that's at play. So when we think about the healthcare system, we're talking about the delivery of care to individual patients. We're talking about the hospital system, who works in certain jobs versus others. What does it mean to have pay disparities within the hospital system? We can also talk about our lives as medical students, training to become part of the system, correct? So what does it mean? What are structural barriers to having a representative physician workforce? So for example, we know that the country is about 13% Black, and somewhere between, I think now we're pushing 19-20% Latinx, and nearly 1% Native American. But what does it mean when our physician workforce doesn't look like our American population? So instead of being 13% of the physician workforce, Black physicians only make up 4% of the workforce, and I think only about 2% of us actually make it into academic medicine. Similar statistics for Latinx folks, where they're nearly 20% of the population now, but still something like 4% of the physician workforce. And so how does that impact the way we're able to deliver care down the road? And so just kind of thinking a little bit more broadly about all the things that lead up to the actual patient encounter. And then we get to the patient encounter where there are ways that we've segregated healthcare in overt and more subtle ways over time. So here we see this picture. This is a public health service dispensary in DC. And one of the most obvious things here, of course, the two signs, white men's waiting room versus colored men's waiting room. That's obviously something we don't see in our hospitals today, but was very common, obviously, in the Jim Crow era, where you had separate entrances for Black folks and white folks, or people of color and white folks. But I think some of the history that we kind of take for granted is the fact that, for example, Black people were not allowed to go to white hospitals. There was a such thing as a white hospital and a Black hospital. If you were a physician, which is really rare to be a Black physician, a lot of times you wouldn't get hospital privileges at various like white hospitals in particular, hence the formation of Black hospitals. Same thing if you were a Black nurse, not being able to practice in a white hospital. And even when there was any sort of mixing, sometimes, you know, there's always this concern about, from like white patients, about Black providers taking care of them. And that's something that we hear about even today. And then kind of beyond that, even if you had a hospital building that was by and large integrated, quote unquote, they would, you know, have separate wings for Black people and white people. And so that's kind of a little bit of the history that I think we have forgotten, perhaps, but that we see that has morphed in different ways over time. So I just wanted to talk a little bit about the history of desegregating hospitals, which is really fascinating and also really terrible. Thinking about the fact that all this stuff is happening in the 40s, 50s, 60s, and my parents, my grandparents, lived through this stuff. And to think that this is not distant history, this is very recent, is a little bit alarming sometimes, I think. But especially in this political moment, we need to reflect back on where we've come, the barriers we've faced, and how it's so easy for this history to repeat itself. And so I'm really interested in history, and particularly medical history, and the ways that we're not taught it in medical school. So, for example, have any of you heard of the Hill-Burton Act? I certainly didn't until I started looking more into this stuff. So I'm just going to kind of run through this really quickly. So the Hill-Burton Act of 1946, essentially, this act provided some funding for constructing and improving hospitals. And that was theoretically going to become a mechanism for desegregating hospitals, because there was this required equal treatment clause. But there was also this separate but equal clause, kind of like the public education system. And so, as we know from, Brown versus Board of Education, this whole separate but equal thing never really works. So what hospitals would do is they would, you know, play this game where it's like, if this wing of the hospital receives federal funding through the Hill-Burton Act, like Wing A, it has received federal funding. That part, you know, needs to be integrated. But like this other part, Black people can't go to, like Wing B does not receive federal funding, however they would wish to make these distinctions. And because Wing B technically doesn't receive federal funding, Black patients can't go there. So, and it ends up, in effect, still having this this weird model of segregated care. And then on top of that, even the funding mechanism itself continued to favor white hospitals. So white hospitals were receiving more federal funding than Black hospitals anyway. And then, you know, about a decade later, there were 3 African-American physicians who wanted to work at the James Walker Memorial Hospital and were denied hospital privileges. So these 3 physicians filed a suit against the hospital claiming discrimination and violation of the 14th Amendment because they were not given hospital privileges. And unfortunately, they lost this case. So that was kind of created a precedent for the 1962 case, Simpkins versus Moses H. Cone Memorial Hospital, where this time is actually a Black dentist who was denied privileges at this hospital. And in this case, the NAACP worked with Simpkins as well as getting together some other Black providers and patients to sue the hospital. And it was this act, or this lawsuit, that struck down the separate but equal clause of Hill-Burton. So technically, hospitals who receive federal funding were required to integrate. And I think that's kind of interesting that we don't quite learn about this particular piece, this particular lawsuit. And everyone's very familiar with Brown versus Board of Education. And I think it's also important to remember that, like, we had our own, like, legal battle to have integrated hospitals. But of course, you know, like, telling hospitals, you know, you need to integrate, otherwise, like, you need to integrate if you're going to receive our funding, doesn't mean that this happens in practice. So it actually took a little bit for things to start coming into effect. So the Civil Rights Act of 1964, I think other people are familiar with the Title VI in particular. No person, essentially, like, shall, on the ground of race, color, or national origin, be excluded from participation in, be denied the benefits of, or be subjected to discrimination under any program or activity receiving federal financial assistance. So it really was this act that essentially forced hospitals to integrate. And so that was a really big deal. And so that's when you start seeing the disappearance of, like, the separate entrances, the separate wings, the separate hospitals. And part of creating this integrated system, of course, means that you're moving toward equality. But I think there are multiple ways where we've kind of maintained inequity, and that's where the Social Security Amendments of 1965 come into play. So in terms of, so outside of actually going to a hospital, seeing a doctor, receiving care, there's also the flip side of reimbursement, which is what we care so much about with SNAP, right? And thinking about the way that our healthcare system is set up such that medical insurance comes through your employer. And prior to the Social Security amendments, literally people just got their healthcare through their employer or out of pocket, essentially. But the beauty of this amendment is that we public laws in 1997 established Medicare and Medicaid, and that was a really big deal, right? And essentially, those public insurances created, I guess, public insurance through Medicare, Medicaid really changed the game in that it created like large pools of people where, you know, your ability to access healthcare has nothing to do with your employment. It means that if you are an older adult over 65, you're able to receive health insurance. And so in many ways, these programs are equalizers for many Americans. And this like really revolutionized like the way we provided care. And because so much of people's access to healthcare depends on whether or not their insurance will reimburse their hospital stay or their doctor's visits, this really changed the game, because at this point, now that Medicare specifically said, you know, we're going to cover all Americans over 65 years old, private insurances were like, so the government's taking care of this, and this is no longer our responsibility. And because of that, hospitals really had this financial incentive to integrate their hospitals, because if they wanted to actually receive reimbursement money from the government for the Black patients that they're admitting, for the white patients that they're admitting, they have to be, one, integrated to comply with the Civil Rights Act, but then also private insurance just like is not going to pay for these particular services. And then of course there's Medicaid for poor folks or disabled folks, and that also is a giant safety net. And so I think it's worth also discussing a little bit about how a way that we've maintained some level of segregation in the US is through the insurance system. So kind of as I touched on, there are multiple ways that people can be insured in this country. I'm sure everyone here with SNAP is familiar. There's obviously private insurance through your employer, which, you know, as of 2016, 49% of Americans receive their insurance through private insurance. And then 7% receive private insurance not from an employer. Then there's Medicare, which covers 14% of the US population, Medicaid, which I think CHIP also, for the purposes of the study I got from the Kaiser Family Foundation, Medicaid and CHIP cover 14% of the total population. 2% are covered by the military or VA, so the Veterans Administration. And then the uninsured rate covers people with like no insurance or have the Indian Health Service insurance only. So there are ways where we've kind of broken things up, where something around like 55% of the population gets their insurance through their employer privately, and then everybody else has some level of public insurance or is uninsured. And so there's a little saying that I'm sure if you've heard me talk or follow me on Twitter or something, you've probably heard me say that insurance discrimination has become a proxy for racial discrimination. And when I say that, what I mean is that there are ways that the healthcare system is set up now such that we don't overtly say we don't take Black patients, right? But nowadays, it's not uncommon for a provider to say, I don't take Medicaid patients, or for, you know, an academic center to say, we do provide healthcare to people who are uninsured, but we have a sliding scale fee system, and even those mechanisms do not always make healthcare accessible to people who cannot afford that sliding fee. So when we're talking about insurance discrimination, we want to see who is that actually affecting. So in the US, the state is a tad old, so I did pull up some other numbers from the Kaiser Family Foundation. And so in the US, white folks make up about 70% of the population, but they only make up 43% of non-elderly folks on Medicaid, and uninsured. The uninsured rate is about the same. 43% of uninsured folks are white. But then we are going to contrast that with Black population, for example. So we're about 13% of the population, but we make up 18% of Medicaid, and 15% of the uninsured population. So we're slightly overrepresented in Medicaid and uninsured populations. For Latinx folks, I know it says there, this is from like 2010 census, that Latinx folks are 16.3% of the population. Now it's closer to 20%. And they make up 30% of the Medicaid population and another 33% of uninsured adults in this country, which is quite significant, right? A difference of, over 10%. And then if you look at, because, we collect data in a particular sort of way, we can talk about this another time, but Asian American and Pacific Islanders have been counted for the purposes of the government, like as an other group that sometimes also gets lumped into like Native Hawaiian and Native American. And so that population is about, in total, like 5-6% of the population, but make up like 10% of Medicaid and another 8% of uninsured patients. So it seems like kind of like relatively small-ish differences, but when you remember how big this country is, and remember that like relative to their proportion in the U.S. population at large, there's this overrepresentation of Black and brown folks in Medicaid and uninsured populations. And that becomes relevant because there have been surveys about physicians in an outpatient setting, for example, who, when you ask like, what percentage of your patients do you see who are Medicaid or Medicare versus private insurance eligible or are on these different insurance plans, you see that significantly fewer people, physicians, accept Medicaid patients compared to Medicare or private insurance. And so when you say that the Medicaid population is disproportionately Black or brown, and they're less likely to receive insurance or to receive health care because physicians say, I just don't take your insurance. I think it's important to like put that into perspective and realize that it's another way for Black and brown people to be excluded from the healthcare system or to see another barrier to access to care. And I think that makes a difference for our single payer model. So I think as you all are familiar with HR 767, the House of Representatives bill for expanded and improved Medicare for all. And part of the reason why we say Medicare for all is important is because it essentially equalizes everybody. To say that everybody is in the same pot, we're all in this together. If you're doing well, I'm doing well. If you're getting access to healthcare because you're on this one insurance plan, I'm not going to get preferential treatment because I'm on a different insurance, and my other neighbor is not going to get essentially discriminated against because they're on another form of insurance. So creating this like level playing field could be a real game changer. And I think that's kind of, I want to emphasize that this is a solution, hence like crossing out the "the" here. There are many issues, as we talked about at the very beginning of this presentation, many issues to regarding racial health disparities. And to say, single payer is going to be, our one-size-fits-all solution to racial inequity, I think is not an honest assessment of the problem. It solves an issue toward the end of the actual delivery of care to our patients. But if we're not also considering all the things leading up to our patients being actually able to access their doctors or their hospitals, we're not really solving the problem. So I think when we are doing our single payer advocacy, for those of us who care about racial justice and social justice, being able to explain to other people that single payer is essentially a form of integration, and that separate but equal is not something that has ever worked in the history of this country, and separate insurance streams is not a form of equality. I think that's one way to perhaps reach different audiences when we're doing some of our single payer advocacy. But at the same time, I think we also should remember that this is one piece of the puzzle, and once we get single payer, hopefully in our lifetime, the work is not done. We have to continue pushing back against all forms of discrimination, about all the things that happen upstream of patients actually making it to our doors. You have to think about built environments. You have to think about how we get equal representation for Black and Brown physicians. All of these sorts of issues are all intertwined, but a good place to start is single payer. I'll also sidebar that for the education piece, so much of our training is funded by Medicare. So another reason to push for single payer is that it actually is going to fund training physicians. And hopefully that also, carry over in terms of the Title VI, rights for the Civil Rights Act. And so, yeah, that's kind of my general spiel. I know it's a little bit on the short side, which I'm sure folks are not particularly upset about. And I know that there's a football game playing, and if you live in Philadelphia, that kind of is important or something. But so I just wanted to close with this quote from Dr. Nathan Moselle, who was a graduate of the University of Pennsylvania. And he said that with all, we wish it had not been necessary to establish the Douglas Hospital, which is, as an aside, was a Black hospital staffed by Black physicians and Black nurses, and was involved in the training of those folks. We deprecate the present trends in the dominant public mind to create, in many sections of the country, hospitals and medical schools, especially for colored people. It means extravagance, inefficiency, duplications of effort, and it is undemocratic in that it establishes caste. So if we are to establish a democratic society where things are equal, one of the places we have to start is in healthcare and in Medicare for all and single payer. So that's kind of my bit. I don't know if it's possible for anyone to ask questions, but if you would like to, I'm happy to stick around for a little bit and answer questions. But otherwise, thank you all for sticking around with me on your Sunday evening.
Thanks so much for the talk, Dorothy. People can either unmute themselves and ask a question, or they can type one into the chat box. But I just wanted to thank you for the presentation. It was wonderful. I thought you brought up a lot of really good points. I think it's easy to think about single payer sort of in the context of maybe like a health policy lecture you got during med school, where it just sort of painted as like dryly figuring out how to pay for something and is this way better than that way. But I think it's important to root this and contextualize it in the lives and experiences of our patients and the people that are affected by said policies. Does anyone have any questions?
If you have any questions in the future, you can also find me on the interwebs. Probably easiest is on Twitter, honestly. So if you think of something else, feel free to tweet me at DN_Charles. I hope that this was helpful for some folks. Thanks for having me, guys.
No problem. Thank you again. I just want to plug two more things. Our final SNAP webinar series is next week. Anad's going to give a talk on Political Advocacy 101, which I think is helpful for any SNAP chapters, if you've been around for a long time, to get a refresher, if you're a new chapter, to learn some concrete skills about organizing and advocacy. I think tonight is also the last night to apply for the SNAP Summit, the travel scholarships to the SNAP Summit that's going to be in New Orleans on March 3rd this year. So if you haven't applied yet, get on it. You still have a couple more hours to apply to that. And lastly, this lecture has been recorded. It'll be online. This is something you can take back to your SNAP chapters or show to your friends and sort of arm yourselves with the skills to talk about these issues.